Okay, let's talk about case number 16. So I see in this case that you have a patient, she's 26 years old, G0, and you took her for hysteroscopic myomectomy. Now, is this the first treatment that she had for her symptomatic uterine fibroids?
So, she had come to me with abnormal bleeding, and in part of the workup, I did the pelvic ultrasound, and so yeah, she was found to have a large submucosal fibroid. So, I did offer hysteroscopic myomectomy as part of that. Yes.
Tell me how you counseled her about the findings in your workup and your recommendation for treatment.
Sure, yeah. So, in terms of the findings of the workup, we discussed the location of
Mic
the
off.
fibroid being within the cavity of the uterus. And so that's, one of the more likely reasons why she'd be having prolonged heavy bleeding. And I discussed with her that the treatment of choice for fibroids really depends on the location of the fibroids. And so, because it was within the cavity of the uterus, the recommended way of treating that would be through resection through a hysteroscope. So we talked about risks and benefits. So we talked about risks of things like bleeding, infection, uterine perforation, fluid overload very rarely, and benefits being that we were able to visualize the fibroid and remove it and hopefully improve her bleeding. In terms of expectations for recovery, we talked about how the procedure is relatively short. It's done typically in the surgery center for this patient, and she would go home same day, not really have too much downtime, maybe some spotting bleeding that day and cramping, and that would hopefully help with the problem of her location of that fibroid.
Using the FIGO classification system, how would you describe this myoma?
So I would say it was like 0 to 1, so more than 50% in the cavity for sure.
Does the size of the myoma impact your recommendations regarding treatment?
Yeah, so if the fibroid's very large, then the so there's only so much fluid deficit that we're allowed to have with hysteroscopic myomectomy. So anytime you're resecting fibroids and opening up big blood vessels, more fluid goes into the uterus. And so, if we would have to stop at whatever fluid deficit. In normal saline, I use 2000. So if it was a very large fibroid, then I would have talked to her about the expectation that perhaps we would need to do this in multiple settings, or if there were many other fibroids and they were more within the uterus, within the wall of the uterus rather than in the cavity, then I would have discussed with her more of a other laparoscopic or open myomectomy approach.
Now, you mentioned the size. Is there a certain size beyond which you feel like removing the myoma in a single setting is unlikely?
I mean, probably anything bigger than like 5-6 centimeters. I feel like that would be really big, and I would probably not be able to get it all in once.
And you talked about a fluid deficit of 2,000 cc's. What distension media do you use for your hysteroscopic myomectomies?
I use normal saline. I use MyoSure, like more slating type mechanical device with normal saline.
So if you got to a fluid deficit of 2,000, you would stop the case.
Yeah, so because she has no medical problems and is healthy, the max is 2,500. But like I was mentioning before, a lot of times with big fibroids, you can jump from 2,000 to 2,500 with relatively short amount of time. So I typically give myself a little bit of a buffer and stop at 2,000.
Okay. If during a hysteroscopic myomectomy well below 2,000 cc fluid deficit, you're having difficulty distending the uterus and increasing difficulty visualizing the operative field, what would you do?
So if I'm having a hard time visualizing, I definitely want to make sure that I'm looking at my fluid deficit and seeing if it's rapidly increasing, if I'm concerned for perforation. There's also like an outflow valve that typically I open more to kind of clear out the cavity from blood, which could be obscuring it. Very rarely you can like slightly increase the intrauterine pressure to kind of help keep the cavity distended and to be able to visualize better. So those are typically the things I use if I have issues visualizing.
What if you suspected during a hysteroscopic myomectomy that you actually had perforated the uterus? How would you handle that?
Yeah, so that would all depend at sort of what point I discovered it and what instrument I was using for in that part of the hysteroscopy. If it was a perforation with a blunt instrument that was more fundal and hemostatic and I was able to see the area, then I would be more likely to observe the patient. If instead it was a sharp instrument or I'm not able to visualize and I'm concerned that there's bleeding and that the perforation may be lateral, then I would have a low threshold for converting to laparoscopy to view the uterus and bowel from above, from an abdominal perspective, to evaluate what is going on with the bleeding and if there's any bowel injury.
So are you telling me that if you perforated with the MyoSure while you were resecting the myoma, that you would do a laparoscopy?
Correct. Yeah. I mean, there's suction on the device, so it could have easily snagged bowel without me realizing it. So, that's definitely top of mind for potential complication.
Now, when you do these hysteroscopic myomectomies, are you doing them in the main operating room at the hospital, or are you doing them in a surgery center?
No, most of these are done in a surgery center that have capability for laparoscopy, but no, that's not something. Typically, the hospital tries to discourage small cases from being done there and utilizing the surgery center unless there's other reasons for higher complexity.
Do you routinely have a laparoscopic setup in the operating room ready to go when you do a hysteroscopic myomectomy?
I mean, I wouldn't say it's like in the operating room open already or anything ready to go, but it's within reach if necessary.
Okay, so assuming that you did have a perforation and you did a laparoscopy and you were concerned for an injury to the bowel, what would you
Mhm.
do?
Yeah, so I think it would depend on what I would definitely inspect, the pelvis and the abdomen, see if there was anything that I could see visually already that were any like spilled
Yeah,
contents
what
of the
if you could visually see an area of the small bowel that's been abraded or possibly even lacerated?
Yeah. So at this point, I would probably ask my general surgery colleague on call to come in and help me to fully evaluate the small bowel and run the bowel and make sure there's no other areas of damage or injury, and then either with their help and guidance to oversew that area of bowel if we're talking about a serosal injury.
Now, if your general surgery colleague comes in to help you run the bowel, how are you going to do that?
So I leave it to their discretion. I know a lot of them work laparoscopically, in this setting because we're in the surgery center, opening wouldn't necessarily be a wise option because I would probably recommend transferring to the main hospital if that's what we wanted to do. But laparoscopically, you can use bowel graspers
Wait,
and
wait, wait, wait. What were you telling me that if you were going to run the bowel, that if you were going to open the patient, you would transfer the patient to the hospital? You mean you would transfer the patient, like take her out from under anesthesia and move her to the main hospital with a leaking bowel injury?
Yeah, I mean, if there's a leaking bowel injury and there's concern for like needing a resection or a bigger surgery, I think it would probably be in the best interest of the patient to go to the main OR, in the main operating room in the main hospital to have all of the things and tools that they may need that they may not have at the surgery center. from a general surgery perspective.
Okay. How long would it take you to get a patient out of the surgery center into an ambulance and transferred to the main hospital and into the OR?
Yeah, I mean, it's literally right across the street. I can't say that I have any experience having to do this, but I think it would just depend on the acuity of the situation.
Okay. Tell me this. When you run the bowel, how do you do it? Where do you start?
Yeah, so you start from the ligament of Treitz, and then using graspers would kind of look at both sides of the bowel and run all the way down to, the ileocecal junction.
Okay. So I'm going to stop here. I'm going to give you a little bit of feedback, okay?
Okay, please, because we got in the weeds there.
Well, actually, I like everything you said until you talked about transferring the patient to the hospital without evaluating and repairing the injury. I would argue that if you have a patient under anesthesia in a surgery center with a obvious through and through laceration, especially if you have a general surgeon available to come help you, you're probably going to want to deal with the injury and then transfer the patient for post-op recovery. Okay.
Sure. Yeah, I wasn't sure if we were talking about like a more like a worse situation versus like just like.
So my concern is if you don't deal with a through and through injury that's leaking into the abdomen, even in the best case, you're going to have to kind of bring the patient out of anesthesia. You're going to have to move her onto a stretcher, put her into an ambulance, take her across the street, get her into the operating room, put her back under anesthesia. I personally have not seen that as the preferred method in my career. Now, fortunately, most of us don't run into these situations that often, but all the surgery centers are usually set up with transfer agreements so that post-operatively, if somebody needs to be put into the hospital, you can do that. But I would say that you should probably deal with the situation, in this case, the bowel injury, and then transfer the patient. And I would argue that opening a patient in the surgery center is completely possible. You may not have all of the retractors that you might have in the main OR, but you should be able to deal with the issue. Now, I'm going to apologize if anybody disagrees on this, but I think that it's different if you don't have an injury. If you're just observing the patient, transferring to the hospital is no big deal. But if you have an injury, I think you should deal with that first. Okay?
No, that's fair. I'm glad we talked about this because I would not have felt comfortable answering this question before this moment. So,
but actually, everything else you said sounded great. So, I mean, I really liked the way that you progressed through the discussion. This is a pretty challenging case of 4 centimeter submucous myoma. It's definitely not impossible, but you talked about the possibility of a staged procedure. You talked about the fluid deficits and what your usual limits are. You talked about the fact that when you are removing a larger myoma, you do open up uterine sinuses. You can get some extravasation of fluid in that way, so your fluid deficits can go up relatively rapidly. All true. You talked about using the MyoSure if you had difficulty visualizing how you would troubleshoot that. And then, of course, when I gave you the perforation scenario, you had a low threshold to do a laparoscopy, completely appropriate. And I think the issue that I knew was starting to develop was the location. Being in the surgery center, and if you haven't had a complication in the surgery center, you may not have thought about what you're going to do. So, okay, good.
Thank you.
Yes, questions for me before I let you out of the hot seat?
No, yeah, I mean, I think the fact that we use the surgery center a lot makes you think about, okay, what would you do if those complications happen? So it's good to talk it out.
Okay, great. I'm going to let you out of the hot seat. Let me just get to the, how about case number 10?
Okay.
So this patient, was she coming to you for something else like an annual exam and just happened to complain of vulvar itching? Was she referred to you from a primary care physician? How did she get to you?
She was referred to me from a primary care physician for intractable vulvar itching.
Okay. And what did you do when she got to your office with that complaint?
So first, I got a detailed history and about how long her vulvar itching has been going on for, if she's had any prior workup or treatment for it. And then I did a focused physical exam, namely a external vulvar exam and pelvic exam to see if I could see any abnormalities that could lead me to an etiology for her vulvar itching. I did collect a swab to swab for vaginitis. On exam, I did note that she had classic signs of lichen sclerosis.
What are the classic signs of lichen sclerosis that you're referring to?
So typically thin white parchment paper skin, usually on the labia minora or labia majora, can also extend around the anus. For severe lichen sclerosis, you can also get changes to labial architecture, involution of the labia minora, phimosis of the clitoris.
So when you have a patient who presents with a vulvar complaint and your examination has some abnormal findings, how do you decide whether or not to do a vulvar biopsy? Because I don't see one documented here.
Correct. I did not do a vulvar biopsy for her because her exam findings to me was consistent with lichen sclerosis. So I decided to empirically treat her with topical corticosteroids to see if her symptoms would improve with that. If her symptoms did not improve with that treatment, I would have proceeded with a vulvar biopsy.
Okay, are there any other situations or reasons in which you would do a biopsy besides a patient who doesn't improve with treatment of an empiric diagnosis?
Yeah, so if she had atypical exam findings that were not classic for lichen sclerosis, if she had a distinct mass or lesion on her vulva, I would have biopsied those as well.
So tell me how you treated her.
So I treated her with a high potency topical corticosteroid. I used clobetasol. I use kind of a tapering regimen where I have them apply the corticosteroid nightly for a month, and then taper down if their symptoms begin to improve.
Okay, taper down to what?
So I would first have them taper down to every other day, and then twice a week.
Okay, and then how long would you treat them twice a week?
So you can consider treating them for twice a week indefinitely if their symptoms are, have been persistent and severe for a long time. But if they experience rapid improvement in symptoms and improvement in their exam, you can consider discontinuing it to see if their symptoms will repair.
Now, do you think that a patient's symptoms will recur if they actually have lichen sclerosis?
It is likely that they will, yes.
But you still would not do long-term therapy? You would still, if they had resolution of their symptoms, you would stop it and wait for it to recur?
The way you're asking this question makes me want to rethink my answer to most likely just continuing a patient on this therapy long-term.
Okay, if you continue a patient on high-potency corticosteroids long-term, don't you think that could be potentially harmful for their vulvar tissues?
It definitely could end up in, thinning of their tissues. I would make sure I follow these patients closely with frequent exams, make sure they're not experiencing any adverse side effects from the medication.
Okay, what kind of adverse side effects would you expect from long-term corticosteroid use on the vulva?
You could get thinning of the skin and erosions.
Do you think that would be likely?
I think if they're using corticosteroids very frequently for a long period of time, it is possible. I think if they're only using it twice a week, it's probably unlikely to have that effect.
Now, if a patient has lichen sclerosis, what do you tell them about the diagnosis and about the long-term ramifications?
So I tell them that this diagnosis it's a chronic disease that's caused by changes in the architecture of their skin. It does put them at slightly higher risk of developing vulvar dysplasia and vulvar cancer down the road.
Do you think if a patient is on long-term maintenance therapy with clobetasol that it would decrease their risk of developing vulvar carcinoma?
That's a good question. I think it would, because it would kind of help manage the chronic like irritation to their skin that is occurring with lichen sclerosis.
So are you saying yes?
I think yes, it would decrease their risk of developing vulvar cancer down the road.
Okay, I want to stop for a second. I want to ask you a couple of outside the exam questions, okay? Looking at this case on your case list, would you anticipate this would be a difficult case in the exam? I think I tried to do that. I kind of insinuated at the beginning, why didn't you do a biopsy? Did you get that feeling?
Yes.
And it is absolutely not required. And you gave me a very reasonable answer that this was a classic exam. And so then, of course, what I'm going to do is I'm going to ask you, well, tell me what is classic, which increases the pressure a little bit more because, you don't usually have to verbally describe your exam findings. But again, you gave me a reasonable description. And then you talked about your treatment, clobetasol. That's exactly how I treat my patients with lichen sclerosis. But of course, you have no clue about that, because I'm not telling you about me. I'm just asking you questions about you, which makes it hard because, as the pressure mounts, then we potentially feel like, oh, I'm saying something else I shouldn't have said. Everything you told me about reasons to biopsy, if the patient doesn't improve, if they have an unusual exam where the diagnosis might be in question, or if they have something that could be cancer, a mass or an ulceration, absolutely going to do biopsies. I completely agree. I thought that was a great answer. How would you treat the patient? You talked about a taper, and I kind of started the slide into the maintenance therapy discussion by asking, well, what kind of a taper are you talking about? And you told me nightly for a month, and then you would start to space it out eventually to twice a week. It's exactly how I would do it. And again, you have no clue, right? That's how I would do it because the examiners don't give you any meaningful feedback. And then I got you to kind of say you would stop treating, and then you sort of said you wouldn't stop treating. And then when you told me you would do long-term treatment, then I sort of asked you about, isn't that going to potentially be harmful? And how did you feel when I asked you that?
And then I started to think that maybe you tricked me and I should have stopped treatment.
It is, and so here's the thing: they're going to do this to you in the exam. So what's the right answer? And this is really my point. And I think you did well with this overall. Even though I got you to flip flop, you didn't give up. The right answer is, what would you actually do? And I think the end question: does maintenance therapy with clobetasol potentially decrease the risk? Probably answers the question about whether maintenance therapy is preferred or not. There is evidence that long-term maintenance therapy does decrease the risk of vulvar carcinoma. And so for that reason, maintenance therapy is probably the best choice, and ACOG sort of hints at this in their publications. And the thing they talk about, the risks of long-term topical corticosteroids, really never been proven. They're kind of theoretical. The idea of thinning skin and breakdown of the skin, never really been shown in any scientific way to be likely. So I agree with you. I think it's not likely. And I thought overall, the way you played this case about as good as you could, considering that I kind of put you in the difficult spot from a couple different angles. So questions for me before I let you out of the hot seat?
No, that was super helpful. Thank you.
Okay, and I really want you to know, I like your approach. Even though I got you to flip-flop in one spot, I still would have left this discussion feeling good about you, okay?
Okay.
But I want all of you to experience this feeling before you go to Dallas, because they're definitely going to do it to you, and they're going to do it with cases like this that don't seem like they're very difficult cases that you kind of aren't anticipating to be controversial, and they're not. It's just that the way they put the pressure on you makes it feel that way. All right, very nice job.
Both on my case list.
Okay, so the first question I have for you is, when you have a patient who's looking for effective birth control, how do you counsel them about the differences between, for instance, the implant or a levonorgestrel IUD or a copper IUD, the pros and cons, risks, benefits? Because I imagine for a lot of patients, they don't really know which one to choose.
Yes. So when I have a patient come in saying that they want an intrauterine device or intrauterine system, I talk to them about the differences. Most commonly, patients come in thinking about the Mirena IUD, and that's the levonorgestrel 52 milligram IUD. I counsel them that this IUD does have progesterone in it, so it works for contraception, and it has an extra benefit of lightening up menses, or possibly making them amenorrheic. So compared to the Paragard, which is a copper IUD that does not have any hormones, it's good for 10 years. However, there are side effects since it does not have hormones in it. It may make the periods a little heavier, a little longer, a little more painful.
Okay. What about the implant compared to those two?
The implant, also the next one is etornogestrel implant. So it is a progesterone-only implant. Counsel them that the benefit of it is that they do not need a pelvic exam for this to be placed. They can be placed in their non-dominant arm, which will be done in the clinic. Once it's placed, it is good for 3 years. It is the most effective contraception that we have, but they need to give it 1 week after placed to be fully effective. So with this placed after a week, they have great contraception for 3 years. However, the side effects.
3 years. If a patient comes in at 3 years and 6 months with an implant, do you think she's likely to get pregnant because she went past the 3-year mark?
So from what my understanding is that it is being studied to see if it is effective for longer than 3 years, and the amount of the etornogestrel that's released every year does decrease. However, I go by what's recommended by the FDA, and the FDA recommends it for 3 years. So I'd highly recommend an exchange to help prevent an unwanted pregnancy.
Okay. Tell me, if you did an exchange, would you make a separate incision to place the new implant?
It depends on where the previous implant was placed. So when I place the Nexplanon on, I look at the non-dominant arm, place it at a 45-degree angle, feel for the medial epicondyle, and go about 8 to 10 centimeters more proximal towards the axilla, and then about 2 to 3 centimeters down from the midline, now to prevent from any injury to vessels. So if the previous implant was placed in the area that was previously recommended around the vessels, I counseled them that I would need to make a separate incision for placement.
Okay. Now, let me ask you, if you have a patient where you can't palpate their previous implant, how would you handle that?
I would counsel the patient that I cannot feel the previous implant, so I would not feel comfortable going ahead and doing an exchange until I know that the implant's in the correct position. So I would move forward with getting an x-ray, since the next one is radio opaque, and so it should be able to be visualized on x-ray.
Okay. Let me ask you a somewhat related question. What if instead of the implant, the patient had one of those Mirena IUDs that you were mentioning a lot of patients ask about, and the patient came for a replacement of her Mirena, and you went to do the replacement and you couldn't see the strings, how would you handle that?
The first step I would do is try to see if I could pull these strings down, see if it's just caught inside the cervical os. So at first, attempt to use a cyto brush to help see if I can bring the strings down. If I cannot see the strings that way, I would try to attempt to grab them with alligator forceps. And if those are unsuccessful, I would stop the procedure and recommend getting a pelvic ultrasound to assess if the IUD is inside the uterus.
Would you do that ultrasound right there on the spot in your office?
If I had an ultrasound openings, I do have an ultrasonographer in the office. So if my ultrasonographer was able to do it, I would prefer to do it the same day. Otherwise, if the ultrasonographer is not available, then I would recommend doing the procedure after I'm able to have an ultrasound done.
Okay, so assuming that it's not available the same day, you would have the patient get scheduled for an ultrasound, and what would you do in the interim?
In the interim, I would counsel the patient of the physical exam findings. I would recommend, depending on if the Mirena is expired versus if the patient has wanting it exchanged due to heavier menses, to use some backup birth control, so using condoms until the ultrasound would be able to be done.
Well, wait a minute. How do you know that there's even a Mirena in the uterus?
I don't know, so that's why I would want her to have some backup birth control to help prevent pregnancy.
Oh, okay. I misunderstood you. When you said that depending on, I thought you were saying that you might sometimes do backup contraception, you might not. But I guess what you were saying is if she had some other method and was only using it for bleeding control, like say she had a tubal ligation or something, then obviously you wouldn't be worried about that. Is that what you meant?
Yes,
Okay.
correct. Sorry about the misunderstanding.
No,
when I have
no problem at all.
normal bleeding, a lot of times they do have a tubal or their partner's had a vasectomy.
Okay, no problem at all. Let me ask you this. So you do the ultrasound, or you order the ultrasound and it's performed, and the results come back no IUD in the uterus. Now what would you do?
Next, I will counsel the patient on the findings and recommend that we do further evaluation to see if the IUD is located inside of the abdomen or pelvis. So I'd recommend getting an abdominal and pelvic X-ray.
Okay, an X-ray. You
Correct.
said. Okay, you don't want to get a CT scan?
No, I don't, because doing a C-arm or an X-ray should be able to locate the IUDs. It should be radio opaque.
Okay, so if you do get the X-ray and it does show the IUD in the abdomen, what would you do?
I would counsel the patient on the findings that the IUD is located in the abdomen, not in the uterus. And I would, recommend removal via laparoscopy.
Is it an emergency?
It is not an emergency. So if she is not having symptoms, we do not have to proceed emergently. However, if she's starting to have pain or having a lot of anxiety from it, then we can proceed.
Have you ever placed an IUD and had it end up in the abdomen?
I personally have not.
Now, I want to stop for a second, just a brief timeout. For anybody who's on this webinar, who's in the exam, if you get a question like that, that is a very challenging question, because you sort of feel, if you have had that happen, that you did something wrong. And at the same time, if you did have that happen and you say no, then you feel like you're lying. So if you do enough of anything, you eventually, unfortunately, experience a complication. So the one piece of feedback I want to give everybody listening is, if you have had this situation happen where you place an IUD and it ended up in the abdomen and they ask you this question, don't feel bad about saying yes, unfortunately. And you notice how I inserted that word unfortunately. Yes, unfortunately, I have had that experience, and it's something I really hope I don't have again. And that's a very honest answer. It's taking ownership of what happens in clinical practice, and the examiners are not going to mark you down for it. So I just want to make sure that point is clear. Dr. Eads, let me get back to you with this question. So when you place an IUD, what steps do you take to try to make sure that the IUD ends up in the correct spot and not in the abdomen?
When I do an IUD placement, I first do a bimanual exam to see if I can feel the position of the uterus, feel if it's introverted or retroflexed. I then place a speculum to visualize the cervix. I clean off the cervix with the antiseptic solution. I place a tenaculum, depending on if I feel the position of the uterus. If it's antiverted, antiflex, I usually place it on the anterior lip. If it's retroflex, I usually place it on the posterior lip. I then use a sound to measure the length of the uterus. After I do that, then depending on which IUD I'm using, I will move the marker down to match the measurement of the sound.
Do you do an ultrasound after you place the IUD?
I do not always.
Really?
No. If the procedure went well and the IUD was easily placed and was consistent with my uterine sound, I counsel the patient on what symptoms can be normal and not normal. And if I have any concern that the symptoms she's having is not normal, then I'll get an ultrasound. I'll also get an ultrasound if the placement was difficult.
Do you require patients to have STI testing prior to getting an IUD placed?
Yes.
So you would make them come in for a separate visit to have STI testing and then schedule them to come back for the placement?
Not always. Typically, my usual steps are to have the patient come in for an IUD consult or talk to them about contraception at the well woman exam. If they just said they want to proceed with the IUD, I do STD testing at that time. If there's something deviates from that or realize that's not been done, I will do STD testing at the time of placement. I won't delay placement.
If you did STI testing at the time of placement, and then unfortunately the results came back positive for chlamydia, what would you tell the patient?
No, I would counsel the patient that she is positive for chlamydia, so she did have a sexually transmitted infection at the time of placement. I would first ask her how she is feeling, if she's having any symptoms. As the STD could, there's a small chance that pelvic inflammatory disease or a infection could go more upward in the pelvis. But I would go ahead and treat her. For chlamydia, typical treatment for chlamydia is 100 milligrams of doxycycline twice daily for 7 days.
Okay, would you do anything else?
I would also counsel her about expedited partner testing or treatment, excuse me. So if, I would recommend that her partner be treated and ask if she is able to give me information for partner to be able to do so.
Would you recommend a test of cure?
Yes, I would recommend a test to cure 3 months after treatment.
Okay, I'm going to stop here. I'm going to give you feedback. Okay. So the first thing I'm going to tell you is that I thought this was a very nice discussion, and you seem very comfortable talking about what you do. And I really got the impression at different places along this discussion that you do a lot of contraceptive counseling and you use a lot of LARC methods. And early on in the discussion about the implant, it was going so good that I decided that let's not talk about the implant because you obviously know that well, okay? Particularly when you started talking about the anatomy and the placement, I was like, okay, we're going to move on. That's going to happen in the exam. You'll get onto a topic you really like and you feel like you're doing well, and then they'll just change directions on you because they figured out you're doing well. So there were a couple of key things in here that could have really been important for your passing or failing this particular question, okay? The first thing is when you run into a situation like you can't palpate an implant or you can't see the strings, there is a very important progression that needs to happen about what comes next, and you obviously know those issues. There are some best practices along the way, including when you don't see the strings and you order an ultrasound and the ultrasound can't be done at that moment. All of you remember to mention backup contraception and a urine pregnancy test before the patient leaves the office, because you don't know if the IUD is in the uterus or not. And if it is not in the uterus and she's pregnant, you want to find out. If it's not in the uterus and she's not pregnant, you don't want her to get pregnant. So definitely mention that is one key point. Of course, the evaluation will proceed from an ultrasound, and if it's negative, it will then go to an X-ray. There's absolutely no reason to waste the money or to expose the patient to the radiation associated with a CT scan. So if they ask you that question, you definitely want to stick to your guns. It's an abdominal X-ray. And then if it's intra-abdominal, we do recommend removal, like you said, but it's not an emergency. And I love the way you presented it. It was all very nice. And then I asked you about the question about whether you'd ever placed one, had it in the abdomen. We talked about that already. And then I asked you, what are some of the steps that you take during an IUD placement to ensure that you get the IUD in the right place? Now, you did something there that you didn't have to do. You basically described the entire placement procedure. Did you do that on purpose?
I did.
Okay. And what was your reason? How was that going to be beneficial?
Well, I believe that you were trying to get that I measured the length of the uterus with a sound. However, I didn't know if not mentioning that doing a pelvic exam or knowing positioning of the uterus was going to come into play. So I thought I would start there, and then it's easier for me just to go through all my steps methodically the same way every time. If I deviate from that, that's where I get in trouble.
So I want you to know I absolutely love it. There are two reasons why I think it's a very good strategy in the exam. If they ask you about a particular procedure and they'll let you talk about all of the steps, one, it uses a little bit more time, and you didn't sound like you were stalling. It just sounded like you were being thorough. And two, that way you don't forget anything that's really important. The key things in my mind are the bimanual exam, placing a tenaculum, sounding the uterus, and setting the marker on the introducing device to the correct length. If you omit the bimanual exam, or you omit the tenaculum, or you omit the sound, all of those are going to potentially increase the risk. Even though most of us do all of those, I think it's really nice to say it the way you did. I love it. So good job, and I hope other people listening will adopt the same strategy. Same thing when you're asked about performing any other type of procedure, like an external cephalic version or a vacuum delivery. We always recommend start, if you can, at the beginning. Don't delay, and you didn't delay. You were very efficient. You kept moving, but you were very thorough, and I like it. A couple of other quick things. The STI testing, it's a best practice with long-acting reversible contraceptives. Gosh, excuse me. It's a best practice not to have the patient have to come back for multiple visits. So we do usually do STI testing, but we'll just do it at the time of placement if they don't have a pre-placement consult. So I like the way you discussed that, because you did not make it a prerequisite that they have to have a separate visit. When you do require a separate visit, studies have shown it decreases the adoption rate of LARC contraceptive methods. Regarding the positive chlamydia, I had to kind of ask you a second time to get you to mention the expedited partner therapy. I want all of you to condition yourself that when you talk about treating gonorrhea, chlamydia, or trichomonas, always please mention you would recommend expedited partner therapy, or if you don't do expedited partner therapy, mention you would recommend the partner be evaluated and treated, which is basically saying the same thing. And then the last thing is, I asked you about a test of cure, and I may be a little bit of a stickler on this, but my opinion is that a test of cure is a test that's done approximately 21 days after treatment to confirm that the antibiotic worked. But you told me 3 months, and I would call that a test of reinfection. And in a case like this, I would usually do a test of reinfection, like you said, which is looking at the the likelihood that the patient will be reinfected from either untreated or new partners in the community. Okay?
Okay.
It's a minor point. It's a terminology thing, but I would call that a test of reinfection. Do you have any questions for me before I let you out of the hot seat?
No, thank you for going into detail.
Okay, I want to ask you a question about case number 11.
Okay.
So when you do a TVH, what type of instrumentation do you use to take your pedicles once you've made your colpotomy?
I typically just clamp and cut.
Okay.
And
All right.
suture.
So if you were doing a TVH and like in this case number 11, and you clamped your uterine artery pedicle, and before you could suture ligate it, it slipped out of your clamp, what would you do?
So in this case, I'm assuming that there's some brisk bleeding going on. So I would try to grasp the pedicle and, kind of ensure that I have adequate visualization.
Okay, so you would just sort of reach forward with the clamp and try to grasp whatever you can get?
I wouldn't try to grasp blindly, but I would need to be able to grasp in order to visualize that area.
Okay, so what if you didn't see a lot of bleeding?
If I didn't see a lot of bleeding from that area, but I knew I didn't properly secure my uterines, then I would. So normally when I do my TVHs, particularly on the uterines, I will double tie those pedicles to ensure that I'm not losing them.
Yeah, so here's the question. You definitely thought you had your uterines in the clamp, and you were coordinating with your assistant, and you went to suture ligate, they let the pedicle out of your clamp, but you're not seeing a lot of bleeding. And you reposition, retract, and you can't clearly see the pedicle. What are you going to do?
But I'm not having bleeding at this time.
Not that you can see.
I would discuss with anesthesia to make sure that she's not bleeding into her abdomen from a vital
Okay.
standpoint.
All right, you would notify anesthesia. What else are you going to do? From their standpoint, she's stable.
If she's stable, I would continue forward with the case.
You would finish the hysterectomy?
If she's not actively bleeding into her abdomen and she's not actively bleeding from the site, then I would continue, and I always perform a cystoscopy at the end.
Okay, so why would continuing with the hysterectomy be the best decision?
Why would it be the best decision?
Uh-huh. Because I'm thinking, okay, you have a couple options, right? You could continue with the hysterectomy. You could look from above level laparoscopy. You could convert to an open case. You could continue retracting and adjusting your lights, trying to see the pedicle that you don't see. But you chose to continue with the hysterectomy. Why is that the best decision?
Because I think at this point, it seems that I safely took my uterines if there's no evidence of kind of continued bleeding. And I think at this point, it doesn't seem prudent to necessarily need to open the patient at this point, given that her vitals are stable and we're continuing with the case.
Okay, let me ask you a slightly different question. What if when you were trying to find the pedicle, there was profuse heavy bleeding and you still couldn't find the pedicle? And she's continuing to have profuse heavy bleeding, your field is full of blood. What would you do in that case?
Well, in that case, if I'm unable to safely clamp a pedicle, then she's going to need to be opened.
Okay, would you do a laparoscopy?
If she's actively bleeding, I think it all depends on sort of how profusely she's bleeding and the rate at which she's losing blood.
So if she's bleeding really heavy, like from the uterine artery,
then I think in this scenario, it's likely safest for me to proceed with an open procedure.
okay. So I want to stop for a second. I want to just talk about this. Have you ever thought about this before?
I have. I mean, I usually have a second kind of more experienced surgeon in this case. And I'm like falling into a hole right now.
No, it's okay, because the thing is, in these cases, so many people today are using vessel sealing devices like ligature and this, and that has its own set of issues. But I love the fact that you're doing a more classic approach, clamping, cutting, suturing, and this is something that the examiners will present. It could happen even if it can happen it's more likely that they'll present it if we're talking about a traditional technique, but they could present a bleeding complication during a TVH with any approach. But the bottom line is, the fork in the road is they're either going to tell you hemorrhage or they're going to tell you no bleeding. When I say fork in the road, that's where the case kind of goes two different directions. If they tell you no bleeding, most of us are not anticipating that. We're thinking if we had the uterine artery and we slips out of our pedicle, that we're going to see bleeding. Would you agree?
Right.
Yeah. So we have to think in our mind, okay, what's the possibility? How could you explain if you lose the pedicle out of your clamp and you don't see bleeding? What are the possibilities to explain that?
That you weren't as high up, that you weren't actually at the uterines yet.
I love it. That's the first possibility, is that you didn't actually have the uterine artery in your pedicle. I love it. And what's another possibility?
That she's bleeding into her abdomen and you're not seeing it. She's like in Trendelenburg.
Absolutely. That possibly maybe the artery retracted, it's retroperitoneal, you're not seeing it. So I asked you this question about why would continuing to do the hysterectomy be the best choice? And there are two reasons that are often proposed in this type of scenario. One is that if you can complete the hysterectomy, when you do the other side, you're going to get sort of a feeling for her anatomy, and it might help you to figure out where you need to be looking for the pedicle on the side that you lost. But more importantly, if you can finish the hysterectomy and get the uterus out of the way, it may also make it a little bit easier for you to kind of examine and figure out where you're at. So if the patient's stable and you're not having hemorrhage in your field, converting to an abdominal approach would be unnecessary. And what you described is exactly what the examiners are expecting you to say. Finish the hysterectomy, re-examine the patient, make sure. I love the first thing you told me was you would tell anesthesia what's going on and ask for their impression of how she's doing. That is absolutely one of the first things you want to do, and then continue working, finish the hysterectomy, and then at the end, maybe reevaluate. You could always put in a scope if you weren't sure, to look and see if there was any sign of a retroperitoneal hematoma. And of course, if you mention that, they might tell you there is a retroperitoneal hematoma, so just be aware of that if you talk about looking from above when she's totally stable with no bleeding. And so this is the scenario I think that's more difficult for most people. The bleeding, hemorrhage in the field is a little bit easier. You're going to maybe give yourself a couple of minutes, and if you can't find the bleeder, then you're going to convert. And in most cases, if we're talking about active hemorrhage from the uterine artery, we're going to do an open approach if it's that much bleeding. The one thing I will say about that is you just never want to blindly clamp. In the beginning, I kind of asked you about that, and you made it clear you would not blindly clamp. I know it seems like an obvious statement, but in the pressure of the exam, sometimes we feel we don't always recognize the priorities, and the priority is do not blindly clamp. Better to do an open approach. Okay. And then you mentioned cystoscopy. I think it's nice if you had a case where maybe you wouldn't have done cystoscopy, but then you had some unexpected things go on. It's never a problem to do cystoscopy. In this case, we weren't really thinking about a bladder or ureter injury, but again, the case wasn't typical. Doing cystoscopy, I think, is always a great thing to mention, just being thorough. Any questions for me before I let you out of the hot seat?
No, I think that pretty much specifies it. But it is appropriate to just proceed with an open if she's actively hemorrhaging. Nobody's going to
Yes.
fault you for not doing laparoscopy.
No, they're not going to fault you.
Okay.
If you are having bleeding that's relatively mild but you don't feel like you can continue because you can't find the pedicle, then you might put a scope in from above. But if you give you hemorrhage and you weren't already set up with laparoscopy, your best bet would be to open the patient, because you have to think about the volume of bleeding, the amount of time that you have. It's going to be time limiting. Okay.
Okay.
All right. Great. I love it. Wonderful
Thank you.
case. You're welcome. I'm going to let you out of the hot seat here. Let me get the number 6. Okay. So in this case, in the preconception category, you mentioned titers. Titers for what?
So typically I would be doing titers for rubella to assess immunity, and then depending on varicella history of infection, if they did not have a history of infection, I would do a titer for varicella.
Okay. And then if a patient had a varicella titer that was non-immune, would you vaccinate her?
I would. That would be a 2 vaccine series, and I would recommend that she wait 3 months prior to attempting conception.
Okay. If the patient were already pregnant, would you vaccinate her?
I would not, as that is a live attenuated vaccine, so I would not recommend vaccination in pregnancy.
So what would you tell the patient if she were varicella non-immune and early pregnancy, and you aren't going to vaccinate her? Would you be worried that she might get varicella during her pregnancy?
So if she is non-immune, she would be at risk for infection, but given that I think around 95% of the adult population is vaccinated or does have immunity from prior infection or vaccination, this will be relatively low risk as long as she prevented exposure to any known infections.
What do you call that concept that you just described?
I consider that herd immunity.
Okay. All right. So let me ask you a different question about this patient. Regarding the carrier screening, it says declined. What carrier screening did you recommend to her?
So anytime I talk to a patient about carrier screening, whether in preconception or the initial prenatal visit, I do discuss that there are multiple carrier screenings available. The basics that we consider are cystic fibrosis, spinal muscular atrophy, and Fragile X. But now with the innovations in genetic screening, we are able to expand that to an expanded carrier screening. In my office, we have a 100, 300, and 500 gene panel, but explain to them that as we expand the number of things that we're looking for, the population prevalence does go down, and we're less likely to see those more rare abnormalities.
Have you ever had one of those screening panels give you a positive result for something that the clinical significance was uncertain?
I do not think I've had any patients in my current practice who have elected to do an expanded screening, but I do counsel them that in those screenings, because we are looking at so many things, the likelihood that something comes back positive does go up.
So do you consider those expanded panels to be an acceptable approach to carrier screening, or do you think that's maybe something that's a little bit beyond reasonable?
I consider them acceptable as with the appropriate counseling of what the results might show.
Okay. So you mentioned that there are some things that you would definitely recommend everybody be screened for. Could you tell me what those were again?
So that would be cystic fibrosis, spinal muscular atrophy, and depending on family history of any intellectual disability, would also include Fragile X.
Okay,
Another thing to consider would be the hemoglobinopathy with hemoglobin electrophoresis.
Okay. So let me ask you about sickle cell disease. That's autosomal recessive, right?
Yes.
Is it a serious condition?
So yes, sickle cell disease in its full form definitely impacts quality of life and can have serious disease complications.
So if you had a couple who were both carriers for sickle cell, would you offer them any options regarding how to avoid having an affected infant?
So yes, the benefit of doing, as I discussed in my preconception visits, the benefit of doing this carrier screening prior to conception would open the door for options in the event of a couple who strongly desires to avoid the possibility of an affected sickle cell child. In that case, they could be referred to reproductive endocrinology and infertility for IVF treatment with pre-implantation specific testing for that gene, PGT.
Okay, any other options?
Yes, the other option would be using a sperm donor with no negative testing, if that was acceptable to the couple.
Okay. If a patient has previously had carrier screening, would you recommend they be rescreened in a future pregnancy or preconception visit?
I would not. I counsel them that carrier screening only needs to be performed once in their lives because it is about their genetic composition and that does not change pregnancy to pregnancy. But I may review if they were not aware of expanded carrier panels. I may offer that. I would offer that.
Okay, I'm going to stop here for a second and give you a little bit of feedback. I kind of probed a couple different places in this case because the way that you describe things on your case list is a little bit less specific, which I actually like. I mean, when you say titers, you don't really tell me what the titers were for. I could guess, but I want to kind of explore and hear what you say. Or when you say carrier screening, you know, it's a very general topic. There's a lot that can come under that. And so I like the way you constructed your list. And I think this presents an advantage because especially the thing like the titers is going to cause a number of examiners to stop and say, okay, I got to ask what this is, hoping that you'll not be prepared. Okay. And then I asked you a couple of questions about varicella in particular. And I decided at a certain point to stop because I didn't feel like I was going to get anywhere. However, if you had been a little bit less confident or less capable, I probably would have asked you about a patient getting varicella near the time of delivery. So just be aware that that could be part of the discussion, okay? Regarding carrier screening, I look at it like there are two different sort of key concepts. The first is what we screen for. And the second is some of the associated issues, like whether we screen in expanded panels or for individual diseases. What do we do with patients when both the partners are carriers? These are some of these associated issues. And ACOG kind of handles it this way as well. They have two separate committee opinions that talk about carrier screening. So with that in mind, just to answer a couple of the questions I asked, the expanded panels are fine. ACOG does not condemn those, but they do have some disadvantages potentially if the counseling isn't thorough. And so again, counseling is the key. And it's more common now. I think a lot of places are doing expanded panels instead of doing specific gene tests. But there are a few that are really important if you're asked which ones are required for all patients that you have to mention. And cystic fibrosis, SMA, and hemoglobinopathies would be the three that are absolutely required. Fragile X you brought up, and it's a slightly different discussion, but it would be relevant if there was some contributing factor, like you mentioned, I think mental disability or autism, sometimes associated with Fragile X. So again, developmental delay, that's the words I was looking for, sorry. So again, Fragile X is also reasonable, but not for every single patient necessarily. And then a couple of other questions. We talk about options for patients who have a significant condition like it could be CLPF, could be SMA. They can do a pre-implantation genetic diagnosis like you talked about. They could do donor sperm or donor egg, because either one of those could be eliminating one carrier. Or they could get pregnant on their own, which if they did, what's the chance with one of these conditions that the infant will be affected if both parents are carriers?
25%.
25%, absolutely. And if the infant's affected, then they could, depending on what the condition is, they could potentially have to make difficult decisions about how to manage that. So those are the options that ACOG specifically outlines. And then if a patient's had previous screening, do they need rescreening? The answer will be no. Even though if they were screened many years ago, the tests may include more mutations, or if it's a panel, it may include more diseases. The general guideline is not to rescreen a patient if they've had the minimum screening in the past. And so I like that. I'm going to stop here. Questions for me before I let you out of the hot seat?
No, thank you so much.
All right, good job. Case number 16 on your list.
Okay.
So my first question, when we talk about fetal growth restriction, tell me what's your differential diagnosis when you see a fetus that's not growing according to your expectations based upon estimated fetal weight?
Yeah, so fetal growth restriction, I know, can come from a lot of causes. I think the most common is kind of placental insufficiency. So looking for any kind of reasons why the placenta may not necessarily be perfusing correctly to the patient or the fetus. So for example, like concern for like high blood pressure, preeclampsia. You can also think about other causes, like potentially infectious causes, particularly if you have an early diagnosis in the second trimester. And just looking at another reason could also be just constitutional. So I know that sometimes for patients who are kind of constitutionally small, especially of different ethnic groups, you can also compare to see if it's particularly in every aspect of the fetal growth versus one specific aspect. And of course, if you are worried that the growth restriction is particularly in certain aspects of the body, so like the limbs or like in the head, like the limbs, you'd be concerned for like genetic causes. Like achondroplasia would be something that you're worried about, or if it was in the head, you could potentially think about like infectious causes like Zika if they were in endemic areas.
Okay, now when you're talking about the specific body parts, are you talking about symmetric versus asymmetric growth restriction?
Right. So you would want to make sure that you would try to assess all the different limbs as well as to the abdomen and the head ratio and see if it was symmetric versus asymmetric. If it was symmetric, that would be putting me more towards like potentially looking at constitutional cause, versus asymmetric would be more concerning for like placental malperfusion.
Okay, now are there any pathologic causes that can cause symmetric growth restriction?
Pathologic causes that can cause symmetric growth restriction.
So what I mean is, you said if it was symmetric, that would make you think more about constitutional, and constitutional to me is not necessarily harmful, right?
Right.
Okay. Yeah. So, are there any differential diagnoses that you think of that might be associated with symmetric growth restriction?
I would try to think of symmetric growth restriction. I would be concerned about I would still want to assess for any kind of perfusion issues, like for gestational diabetes or preeclampsia.
Okay, let me ask you this. In this case, you mentioned the estimated fetal weight was less than the 3rd percentile. Is that your criteria for fetal growth restriction, less than the 3rd percentile?
So this would be an example of severe fetal growth restriction. Overall, the definition of fetal growth restriction would be less than the 10th percentile overall. Or if it was specifically the abdominal circumference was less than 10th percentile by itself.
So once you diagnose growth restriction during your antepartum care, how do you modify your antepartum management based upon this complication?
So I always talk to the patient about potential causes of fetal growth restriction and talk to them about, depending on the time of diagnosis, would be talking about adjusted antenatal testing, as well as kick counts and surveillance. I would want to make sure that I was doing, and I would also talk to them about complications that could arise during delivery, such as intolerance to labor or potential need for C-section due to that intolerance, and then also talk to them about the risk of stillbirth.
Would you do serial growth scans?
I would do serial growth scans every 4 weeks to make sure that the fetus was appropriately growing over time, and also make sure to do uterine artery Dopplers. Oh, sorry, umbilical artery Dopplers, not uterine.
Okay. And in this particular case, you induced the patient, and then the patient had a failed induction. When you say failed induction of labor, what are your criteria for that?
So for this patient specifically, she failed her induction of labor because we attempted to start an induction of labor with standard Foley balloon and Pitocin. After Foley balloon placement, with the start of the Pitocin, she was noted to have kind of intermittent late decelerations, for which we subsequently tried to turn off the pit and restart it, given the fact that we were unable to proceed with her induction without it wasn't recurrent, but it was continued intermittent late decelerations, and given the size of her fetus, we counseled her towards primary cesarean delivery due to intolerance of labor.
Okay. Now, if the fetal heart rate tracing had been reassuring and the patient was undergoing induction of labor, what would be your criteria to call it a failed induction?
So for her, failed induction of labor would be failure to reach 4 centimeters or above, so reaching that kind of second stage, and then also failure. So if she was continuing to tolerate, of course, if she were to reach above 4 centimeters of dilation, then we would want to make sure that she was making adequate cervical change over at least 6 hours of time.
Okay, so to call somebody a failed induction, what would the criteria be? I'm sorry, I kind of was hearing different things that might not be exactly the criteria I was expecting.
So for her specifically, failed induction, I think I would just say that she would either have fetal intolerance to any kind of induction, and if she were to have a reassuring tracing, that we would give her, we would try to induce her with our standard measures such as Foley balloon or Pitocin, and that over the course of 12 hours, I would say she wasn't adequately reaching 4 centimeters of dilation.
Okay. Now, what do you consider active labor?
Active labor would be, I guess in that case, it would be active labor would be consistent contractions with greater than 6 centimeters dilation.
Okay, good. All right, so I'm going to give you some feedback about some of the conversation we had here. I think this was a very good starting point. And these cases are senior residencies, so they're from a while ago, right?
Yeah, I haven't delivered a baby in like 2 years, so I'm so sorry. I know my knowledge is lacking.
No, it's okay. So I just want to go back through because I thought this was a good discussion, and I still think there's some room for refining your answers prior to going to Dallas. And so I want to help you with that, as well as everybody listening, because you're probably not the only person who isn't doing OB on a regular basis. And so this is a great case. Fetal growth restriction, very high yield. And, when we think about the differential diagnosis, you talked about sort of placental, infection, constitutional. I like that, giving some overarching categories, and you can kind of fill in underneath if they give you time. When we talk about symmetrical versus asymmetrical, one thing that may be helpful is I think about symmetrical often being things that happen early in pregnancy, and asymmetrical being things that might happen a little bit later in pregnancy, like placental insufficiency for asymmetrical commonly, or maybe like a genetic problem, like a syndrome that might be present from the beginning that might be related to symmetric growth restriction. So again, early versus late is one way to help think about ideas of things that you might mention. Definitely when we diagnose growth restriction antepartum, we are going to be much more intensive in our monitoring of both the maternal and fetal status. Specifically for the fetus, antepartum testing, generally in the third trimester, 32 weeks and beyond for sure. We're going to talk about serial growth scans, umbilical artery Dopplers. I love that you mentioned that. And so then we get into delivery timing based upon whether it's growth restriction, severe or not, whether there are other associated findings. In this case, oligohydramnios obviously would make us more concerned. So I just always have to keep that in mind. Growth restriction by itself versus growth restriction with other complications would advance the timing of delivery. So that's another thing that they may ask you about. And then in this case, the failed induction of labor. Interestingly enough, on your case list, I would not have guessed from looking at this case that you were talking about a fetal heart rate tracing, because nothing on the case actually says anything like D cells or category 2 tracing or intrauterine resuscitation. So I like the fact that it doesn't say it, because what I'm going to recommend is that you take a look at the definitions for 3 specific diagnoses: failed induction of labor, arrest of dilation, or some people would call arrest of the first stage of labor, and arrest of descent, which people would call arrest of the second stage of labor. It doesn't matter which terminology you use. I will give you this one piece of information. When I think about failed induction, I think about inability to get a patient into active labor despite at least 24 hours of trying to induce them, preferably with rupture of membranes and with the use of Pitocin. Okay, so, and I usually think of 6 centimeters as active labor. So if we, if that would be my definition of failed induction, you don't get the patient into labor despite trying for at least 24 hours with rupture of membranes and Pitocin. There are criteria for arrest of dilation, arrest of descent. Please look at those, all of you, because those criteria are really considered important information that you should know. And part of the reason that this is so important is that the most common indication for a primary cesarean delivery like this patient had is going to be a labor abnormality like failed induction, arrest of dilation, or arrest of descent. So makes this very high yield. Dr. Chang, any questions for me before I let you out of the hot seat?
No, I think that was really helpful. It definitely helped me start thinking about ways that I need to really review these very basic kind of OB concepts. So thank you.
Well, they are basic, but there's so many basic things that none of us know them all. And one of the things I always remind people is the reason we do mock orals is we're looking for important concepts that we should probably brush up on and be able to talk about. We don't need to give a grand rounds on growth restriction, but we do need to be able to answer some of these hot button issues. So I love it. Okay.
I actually did have a question before you let me go.
Yeah.
When you're actually answering questions about like differential diagnosis, or like when you were asking me about symmetric or asymmetric, how detailed do you have to go into? Because I did feel like I started rambling.
Okay, so here's the thing. If you have good answers, use as much time as they'll give you. And so for instance, I always like to think about, some people call this the high altitude approach. If you ask me about the differential diagnosis for growth restriction, I'd say, well, I'd be thinking about a variety of things. They could be maternal, or they could be fetal, or they could be placental. That's the first pass. I went from a very high altitude, and it kind of helps myself think about where I'm going to go next. Then I come back and I say, so for instance, Some maternal conditions that might be associated with growth restriction could include, now I want to warn you, any one of these conditions that I mentioned could be the next direction that they go, okay? So I have to, as I'm preparing for the exam, I have to think about which things do I want to say and which things do I want to leave out. But I might say, for instance, hypertensive disorders of pregnancy, which is that's a broad category. And I could say, you know, within hypertensive disorders of pregnancy, I think about things like chronic hypertension, preeclampsia with severe features. Do you see how by laying it out and kind of making multiple passes, getting more detailed as I go, how I could spend a lot of time on it?
Yeah, that totally makes sense.
Yeah, and then I can also, if I practice this before I get to Dallas, I could say, I don't really want to mention lupus because I don't want to be asked about, you know what I'm saying? You can't always guarantee that you won't be asked about it, but if there's something you're not as comfortable with, you wouldn't volunteer it in the beginning. Does that make sense?
Yeah, that makes sense.
And so the bottom line is the answer to the question is be as detailed as they'll let you be, as long as you're doing it on purpose. Because if you are doing it on purpose and you're using that time, it might seem to some of you listening that this is trivial advice. It is not. If I can use 5 minutes on something I want to talk about that I know well, or even that I'm just developing my differential, but I'm doing it in a good way where it looks good for me, that's 5 minutes that we're not spending on something that I don't know. Does that make sense?
Yeah, that totally makes sense.
Okay, did you have a second question? Because I kind of cut you off.
No, that was exactly what I was looking for. That was really helpful. Thank you.
Can you hear me?
Yes, I can.
Yes, I had a couple questions. First, I wanted to confirm when we were talking about the chlamydia case with the IUD, I often, as well as the prior examinee, said that I would get a test of reinfection, usually in 3 months. I just wanted to make sure that usually when we say test of cure, we're mostly just referring to pregnant patients.
Yes, I usually think of a test of cure as something we do in pregnancy. Again, usually 21 days after treatment, and we're basically confirming that the antibiotics worked.
Okay. And then just to make sure for the TPH cases, I also do a lot of VAGs. One of the things I was thinking, would it be appropriate to say just creating a new pedicle and replacing a clamp to create a new pedicle to suture ligate that pedicle? Because I often do cold cut with suture ligation.
You mean if you thought that you had lost the pedicle that you would take the next bite?
Correct. Just on that same size, like if I was working.
And in fact, that's what I would do if I don't have any bleeding. I would see, can I find the pedicle? And if I can't find the pedicle, then I would go ahead and identify my next bite, and I would continue to take my next bite. If I have hemorrhage and I can't see, then I'm not going to blindly clamp. That's the one key thing. But yes, I would continue on the same side, finish my hysterectomy, go to the other side, but I would continue on the same side. I did not mean to abandon that side.
Okay, thank you. And then my last question, I feel like this kind of came up on a couple webinars. Can we confirm the 1 month versus 3 month waiting period after varicella vaccine?
Yes, so the minimum absolutely is 1 month. Okay. A lot of people say 3 months. It's a little bit of the art of medicine, but the minimum is 1 month. For after any of those vaccines, we recommend for 1 month. And the same thing can also be said generally about methotrexate. A lot of people do wait a little bit longer, like 3 months, but technically, I believe the minimum is 1 month.
Thank you.
Yeah, you're welcome. Good questions. And by the way, if you said for something like that 3 months, it's not the end of the world. Even if they pin you down and you stick to your guns and say, I would always tell them 3 months, and they believe it should only be 1 month, that is not a pass-fail issue. Okay?
Yes, thank you.
Okay. And let's see, I think there were some other questions. Dr. Zoma, did you have a question?
Hi, yes, I do. Just a quick question about clobetasol treatment. Can you go over the treatment timeline, and then also how long would you do the maintenance dose for or maintenance treatment for?
So the first thing is that there are multiple different ways that have been described to do clobetasol. So most people will do daily therapy, and the period of time will be anywhere from 1 month to a couple of months. A lot of times it's based upon whether the patient has a good response. So if the patient had very severe disease at the time of diagnosis, then they might be treated for several months before looking for improvement before you start to taper the dose. A lot of times people will go from daily to twice or sometimes 3 times a week. So they won't do every other day or something like that. They'll just go from every day to then 3 times a week or twice a week. And then maintenance therapy is usually thought of as twice a week. That's the most common way maintenance therapy is done. And it can be done indefinitely. And that's what I would generally do for a patient, especially if they're older or they've had recurrences. I would just put them on clobetasol indefinitely, twice a week. Now, this twice a week maintenance therapy is both going to prevent recurrences because it is a chronic disease. And when we stop treating patients, many patients will get recurrences. It's also going to reduce their risk. Although the risk is low, it's going to reduce that risk of a vulvar carcinoma. And so for this reason, this is where indefinite maintenance therapy is considered appropriate and probably the best option. Although if you don't do it that way, you're not wrong, because it's an issue where there are different opinions. The last thing I'll say about this is that the one thing that is not been shown, and ACOG mentions this, I think it's in their practice bulletin on vulvar diseases. We were all taught in medical school that if you use chronic high potency steroids on the skin, that you're going to get these skin complications like breakdown and ulceration and this kind of thing. And they make the point that's never really been clinically shown. It doesn't really happen. It's more of a theoretical concern. So for that reason, that would not be a contraindication to maintenance therapy with clobetasol.
Okay. And if symptoms are controlled, oh, sorry.
Yeah.
If symptoms are controlled with the clobetasol, is it appropriate to just follow up at routine annual visits, or is there a specific timeline that we should recommend they come in just to make sure it's not getting worse, or biopsy is not indicated?
Very, very good question. Now, there's 2 questions there. One is, when is a biopsy indicated? And of course, if a patient's responding and they have no new lesions, then there's no reason to biopsy them, okay?
Right.
Biopsy would be if they are not responding or they have new changes or new symptoms. But the idea about when to follow them up, that is actually an important question. And that has been, there have been things written about that. Ideally, a patient who has lichen sclerosis should be counseled that she should have an annual vulvar exam by somebody with training in gynecology. So it could maybe be a gynecology nurse practitioner or a GYN physician, or maybe a family practitioner that's had gynecology training, but somebody should look at the vulva every single year. And usually we do it in conjunction with their annual exam. But the issue is they might get to a point where maybe they're not seeing a gynecologist because they're not doing cervical cancer screening, or they're just seeing primary care, and those people might not be thinking about the vulva. So they need to have, I always tell patients when I diagnose lichen sclerosis, for the rest of your life, you always should have with your annual exam a vulvar exam, and please just remind your doctor if it's not me, so that they take a look to make sure there's nothing that needs to be addressed. And of course, if we ever see anything, then we should do a biopsy.
Okay, great point. Thank you so much.
Yeah, you're welcome.
All right, hello.
Yes, did you have a question?
Yes, I did. It's kind of specific, just because we were going over vaginal hysterectomies. I wanted to ask, because I looked at my case list and I'm like, man, I probably shouldn't have put this one on there, but I do V-notes hysterectomies for things that I know are newer. I'm not even sure, like things like that. Can you be penalized for that? Like, I feel like they're going to call. Okay.
You're not going to be penalized, but here's the thing. Okay, this is a great question. I'm glad you brought this up. You talked about V-note, just in case people didn't hear what you said there, V-note. I'm going to throw that in with, and it's going to sound crazy, but I'm going to throw it in with JADA. Do you know what JADA is?
Yeah, the uterine device.
Intrauterine device, vacuum, or bleeding. So whenever you use something that's kind of new, vendors aren't going to have any issue with that, but they're going to know about these new things and they're going to ask you about it. So if you're doing something that's kind of cutting edge and new, and I ask you about some of the details about the device or how it works, and you seem kind of like you don't really know, now instead of looking like an early adopter who's on the cutting edge, you kind of look like somebody who will use technology and instruments without understanding them. Does that make sense?
Yeah, I understand.
So you can go from where it's really makes you look good because you're like, up to speed, cutting edge. All of a sudden you're like, not looking so good because you really don't know the details of that stuff. So anytime you're using a newer device, newer technology, or newer treatment, I think there's a little bit higher expectation that you have to have the background about that piece of equipment. And many times we know a little bit of that, but we don't talk about it. So that's why I always recommend to people, look up the specifics about that device. What are some of the advantages, the potential disadvantages, troubleshooting problems that might arise with it. Know it even better than the stuff that you have done for a million years, because, or that have been out there for a million years, because the examiners will ask you. Okay?
Okay. Thank you.
Yeah, great question. All right, I think this brings us to the end for tonight. I want to thank all of you for hanging with us. Wonderful group of folks in the hot seat, a lot of great questions. Tonight is Tuesday. We will have another webinar tomorrow night. So please, in fact, we will have another webinar tomorrow night. And I believe they announced today that because we have so many people on the webinar